Welcome to the Golden Hour, the podcast community where moms and moms-to-be hear stories from other mothers and top experts in the pregnancy and postpartum care field. You can visit goldenhour.fm for more information, resources, and all other episodes. You can also find us at goldenhour.fm on Instagram for comments and questions. Welcome, everyone, to another episode of The Golden Hour. I am your host, Dr. O, and I'm joined by a colleague that I deeply admire, Dr. Eduardo Hariton. Eduardo is a double board-certified OBGYN and reproductive endocrinology and infertility specialist. He received his medical training at Harvard, where he completed a combined MD, MBA at Harvard Medical School and Harvard Business School, and his OBGYN residency at the Brigham and Women's Hospital and Massachusetts General Hospital. He completed his fellowship in reproductive endocrinology infertility at the University of California, San Francisco. He's currently a practicing physician at the Reproductive Science Center of the Bay Area in California. He also serves as the VP of Strategic Initiatives at the US Fertility and the Managing Director of the USF Innovation Fund. What don't you do, Eduardo? Dr. Hariton combines his clinical and business backgrounds to treat patients and think creatively about how to improve their care and that they receive when seeking fertility services. He met his wife, Kim, during the MBA, and they have 3 kids, Sophia, 5, Carolina, 3, and Isaac, 1, who gives his job as a fertility doctor all the meaning in the world. Eduardo, you're busy, man. You're really busy. Not only do you have this abundant practice, but you have a full family full of love and joy. I think you said today that one of your daughters had a school activity.
No, my wife calls me a professional multitasker, but I love a lot of things. I love every part of my job. I love the patient care. I love thinking about the other stuff that we do, and obviously family first. So today you're in my garage of a home office because I wanted to go to my daughter's school and I wanted to see my patients. So I'm working from home today and I'm excited to chat some more.
Yeah, I'm excited. Yeah, truly a master multitasker. And I think as I was sharing with you in the kind of pre-recording, one of the reasons why I was so enthusiastic to have you on as a guest is not only your expertise as a fertility specialist, as well as someone who's steeped in kind of innovative tech and startup world, but you're just so passionate and you're always so enthusiastic about not only teaching your own colleagues, myself included, but patients. And so I'm really hopeful that you're going to be that resource that all patients deserve. And not all patients can have access to fertility specialists, but be able to talk to you today, I think will really hopefully reach a wide audience for those who are lucky to listen. So to get started, thinking about a client who comes to see you for their first fertility consultation, what are some of the questions that client should come into the appointment thinking about already? What are some of the things that you kind of address in that very first appointment?
Yeah, so I would say no one likes to have babies in my office. It's not the fun way. So if you're someone listening to this and this is kind of what's on your mind, just know that you're not alone. The first step is the hardest step, which is to call the clinic, make that appointment. It takes a lot of energy and no one likes to do it. But, for people who need to, it's definitely a great place to get started. If you're thinking about fertility preservation, if you've been trying for more than 6 months and you're over 35, more than 12 months, you're under 35, you have irregular cycles, call me right away. If you have endometriosis, if your tubes are blocked, you've had an ectopic, your partner had an abnormal semen analysis, you don't need to wait 6 to 12 months. We want to see you sooner because there might be something that might make it not work. And we all know how disappointing and hard it is when you're trying and every month you get a period and you're not successful. So we don't want you to feel like you have to wait. If you're concerned about it, make that appointment. The worst thing that happens is you get some good information and then keep trying naturally. That doesn't commit you to doing treatment. So I always start there. When you do come in, I would say in preparation, if you've done any testing, you have done blood work, you have done anything with your OBGYN, so with Ono or someone else, make sure you bring that in, ideally ahead of time. I always like to review all the records ahead of time so that I am the most prepared possible to give the patient the right information. If you haven't done anything, that's also okay. We'll go through the things that we need to do. what I typically do in that first visit is just get to know the patient or the couple. It's, it's a relationship that will take us over months or years together. So really understanding, like, what are your goals? What are you trying to accomplish? How many kids you want to have? What are you open to and what are you not open to? And really getting to know your medical history and that of your partner if you have one. And then we spend most of the time talking about what happens to fertility over time, how does it change, why does it change, what are the things that we need to test. And if we have testing, we interpret those tests and help teach you about what are the different options and deciding, okay, as a next step, if we need to test something, let's go and get that in the books. If we have all the information already, what is the right next step in terms of treatment? So we go through that end to end and comprehensively. And I always hope that at the end of that visit, my patients feel a sense of empowerment to say, okay, information can empower them, and then a path forward can empower them. So I always hope to be like, okay, you learn a lot. Do you have any questions? We go through all of those. And this is what the next steps are. You have to call someone or someone will call you, or this is the test that you need to do, because I think knowing and what's ahead of you is really helpful, and being able to put one step in front of the other through what is otherwise a very complex, expensive, and stressful journey is what's most manageable.
Yeah. I think a constant theme for this podcast is empowerment. And so I love the idea that, patients are coming to you with complex emotions, right? Frustration, fear, anxiety, emotional fatigue. And so at the end of a consultation with you, they can leave feeling empowered, knowing that they have a path forward. I think that that's such a thoughtful way to think about it. And something that you said was kind of understanding why fertility changes. I think I spend a lot of time educating patients about that in my clinic room one-on-one, but the power of a podcast is having a broader audience. So do you mind just kind of explaining in simple terms how and why fertility changes as we age?
Absolutely. Yeah. One of my favorite topics.
Great.
So all women are born with all the eggs they're going to have. And they lose them in utero, they lose them before they even start having periods. And that decline keeps going until they run out of eggs right around the time they hit menopause, which on average is around age 51. As women go through the reproductive years, they have less eggs available in the surface of the ovary that we can work with. And the quality of those eggs declines over time. And it does so more precipitously after 35 and certainly after 40. What I mean by that is when those eggs are dividing from a cell that has all your DNA into two cells that have half of your DNA, so that that half can meet with the male half and create a whole, which is the baby, that cell usually divides abnormally more often as you get older. So the eggs coming out of the ovary at 40 are majority abnormal. When you're 30, they're majority normal. And that transition happens initially gradually and then more exponentially. So that after age 45, almost all of the eggs left in the ovary are abnormal. And when you get pregnant with an abnormal egg, most times it doesn't implant. If it implants, most likely it miscarries. And there's some abnormalities, like, for example, Down syndrome, that can proceed to be a live-born baby. But the majority of the abnormalities are not compatible with having a baby at all. So not pregnant or miscarriage. So as a woman's age rises, you have less eggs available to work with and a lower ratio of good eggs to bad eggs. So it gets harder and harder to find those healthy eggs. And my ability to help someone depends on both how old they are and how many eggs we have available to work with. And that's why you're seeing so many people freezing their eggs early on, because when you harvest earlier, you're going to get more eggs out of one cycle, and you're going to get better quality eggs that you can then use to help that person in the future.
Yeah. Excellent explanation. And I was quizzing myself too, because I was like, yes, I'm saying all the right REI things when I talk to my patients as well. So that's great.
I'm sure you are. I have no doubts.
Great. And so thinking about that, something that you alluded to was egg freezing, so oocyte preservation. And that comes up a lot, I think, especially as someone who has the privilege of practicing in the Bay Area. I have the honor of caring for a lot of professional, career-driven women who are decidedly focused on their careers and kind of deferring family to later on in their lives, and also work for companies. Oftentimes, a lot of the bigger tech companies in our area also have decent fertility coverage, and so oftentimes they're offering packages that include egg freezing. So I very, very commonly will have patients come in for the pap smear, and at the very end of the appointment say, like, by the way, what should I do? Should I freeze my eggs? What are your thoughts? And so what do you say to someone who is considering egg freezing? Is it something that everyone should do? Is it only something to consider if you are thinking about a family later on at a certain age? How do you counsel patients around that?
Great question. I don't think it's for everyone. And that's why I always start with getting to know the patient, because I think it really depends on their goals. Egg freezing is a tool that allows you to maximize your chances to have a biologically related child in the future. If you're going to start trying in 3 months or 6 months, you probably don't need that. But if you want to have 3 children and you're 37 and you're going to start trying in 3 months, I'm not so worried about baby number 1, because if you're not successful with baby number 1 and you're back to me in 6 months, we can probably still help you with the same success. But when you come back for baby number 2 at 40 and baby number 3 at 42, that might not be the case. So the questions I ask my patients are, how much do genetics matter to you? Because if genetics don't matter, if you're okay adopting or using donor eggs, and it's, and most people care, but some people don't, then freezing eggs is not necessary, because you might end up using someone else's eggs or adopting, and that's okay. Most of my patients want to use their own genetics as the first choice. So they do want to think about egg freezing. I ask them, where are you today? When do you think you want to start a family, and how many kids you want to have? And then we think about that. Well, I'm 33 years old. I'm focused on my career, or I don't have a partner. I can't see myself having children before age 39 or 40, and I want to have 2. Well, if you start at 40 and you have your second at 43, there's a pretty high likelihood that we might struggle. For that patient, it does make sense to freeze. If you are 27 and you want to have 1 child and you're with a partner, but you're not ready, you might plan to start in the next couple of years. Probably doesn't make sense to freeze, because you might come back at 29, 30 if you're not having an issue. Egg quality should be about the same. Egg number might be a little lower, but as long as those numbers are still good, you will probably be just as successful in a couple of years as you are now. So I try to individualize that counseling, help patients think about not just that first baby, but the whole family timeline, and then guide them through that. And sometimes they have a partner, if that partner's male and they want to create embryos. That can also be an alternative for couples who know they want to build a family together. Embryos are also an option that allows them to preserve fertility as a couple, not just as an individual.
Yeah. Great summary. And I love the idea of kind of individualizing care. I think so many times there's a lot more conversations, I think, happening nowadays via social media, TikTok, Instagram, et cetera, which is great. One of the reasons why I want to do the podcast, though, is to present information that hopefully is a little bit vetted. And in that, it feels like, patients oftentimes hear something that is, trending on some media platform and make that assumption, well, and I should do that too. Let me catch the wave of that trend. We're really thinking about you as the individual, the timeline of your family planning, your age, all those things I think are really important to factor in. Other things that I commonly get asked is someone who knows they want kids in the future, has never tried to conceive before. So there's no kind of anticipation for any fertility issues, but they often ask, like, I want to know where my fertility is at. I want my numbers. I want to do tests. What are your thoughts about kind of testing your fertility, quote unquote? What do those tests involve? And is that something that people should do if they're not actively trying to conceive?
That's a good question. I tell my patients, infertility is one of those things you don't know you have it until you try. So there are no tests that are predictive of fertility. What that means is that I can't check and say with, full certainty, you will get pregnant and you won't get pregnant. What I tell my patients is that you need 4 things to get pregnant: uterus, fallopian tubes, ovaries, and sperm. And those are the 4 things that we can check. we can look at your uterus on the outside, make sure there's no big fibroids. We can put water inside the uterus to separate the walls and make sure that on the inside there's no scar tissue or polyps or any abnormality that's genetic from birth in how the uterus formed. We can put contrast dye or foam or bubbles through the fallopian tubes, confirm that they're open. If you're ovulating regularly, that means that you're most likely releasing eggs every month and having regular, predictable cycles. Doesn't have to be exact 28, but if it's within a certain range, it's coming monthly, you kind of feel that breast tenderness, cramping start the day before, and then you get bleeding, you're most likely ovulating regularly and releasing those eggs. And we can do testings like ultrasounds or blood work to check your ovarian reserve. And that's how we think about the ovaries. And then the semen analysis is something that we use with males, where we have them masturbate in a cup, and then we look under the microscope at sperm quality. And by that, we mean, is there enough sperm? Is it moving like we expected? Are the shapes what we expect? And those are all the things that we can do. For most people that are having regular cycles, we don't do this testing ahead because the likelihood that we find something is low. But I totally recognize that in my situation, I was there too. I said, I don't want to go into this 12-month process if there's an issue that I could recognize and solve. So what I tell my patients, and interestingly, my wife used to work at Modern Fertility. They were one of the first companies out there that were offering AMHs. And, physicians didn't love that because they're like, well, I don't know what to do with it. It doesn't predict fertility. But I actually think that information is power, right?
Yeah.
And if you do a test, yes, if your AMH is high or it's low, it might not help me to tell you whether you're going to get pregnant over this next 6 months when you're trying. But with a low AMH, you might think about your goals differently. You might think about freezing for that second or third baby, when otherwise you would just start. And then in 2 years, maybe you never get a period back after your first baby, and you wish you had that information before. Same thing on the male side. That semen analysis might not be cost effective for insurance to screen everybody, but this is not everybody. This is you and your partner making a big, important decision. So if you want to do a screening semen analysis just to make sure that the sperm is enough to get pregnant having intercourse at home, I think that's fine. And the best thing that happens is that you get reassured. And the worst thing that happens is we find something, but we can act on it sooner. I typically tell my patients, I'm comfortable testing your hormones. I'm comfortable testing the sperm. The tube test is pretty painful. Most people don't like me when they do that. So unless someone has a history of endometriosis or a sexually transmitted infection like gonorrhea and chlamydia, I'll usually spare them from that one. And then I let them try. And I think that's a good balance of tests that are low risk, non-invasive, not uncomfortable, give you valuable information, but at the same time, allow you to make the right decision for yourself.
Yeah. No, I appreciate that perspective. And I didn't realize that your wife was part of Modern Fertility, because a question I have, and something that comes up for me as an OB, is that we do live in a society that is consumerism based, right? That there is kind of standard healthcare, and then there's innovative healthcare, things that kind of bring the tools that I normally would only be able to order through my office right to a patient's door. And so maybe I'm asking a controversial question now that I know your wife's round of field of work as well. But what are your thoughts about like kind of these home fertility testing options, and what should we as clinicians do when we have patients who kind of bring us these home fertility results? And how do we balance that?
I think that's a great question. And I love controversial questions, but great. I don't find this controversial. It's more of like, there's good eggs and there's bad eggs. I think certainly, the care, when we were babies, all of the care happened in a big academic center, and you had to like drive and deal with parking. And even if you wanted to go see your standard PCP, it was inconvenient and annoying. And then more private practices came along, and, we put, medical offices in retail areas where it was more convenient for patients. And now that can happen over the phone on an app, or that can happen at home without ever seeing someone. And I think the real distinction is, it's not so much about where you get that care. It's about whether the care is appropriate and it's tied to the right counseling. So, sometimes you see a lot of these treatments that are not appropriate for patients, and they're getting patients to the wrong situation. And in that way, it's not the right treatment, it's not the right test, and it doesn't have the right context. So it doesn't get the patient anything helpful. If anything, it confuses them. And some of them are predatory and cannibalistic, where they're saying, like, give me your money, take this vitamin, I will change your life. And the reality is a lot of these things are not validated. It can go wrong. I do a lot of advising for companies, Modern Fertility being one of them, in full disclosure, but several others. And I think my bar is, do I think I'm doing the right thing for the patient? It's okay if it's more convenient, it's okay it's not at home. But as long as it's not skirting any medical guidelines or it's providing snake oil, I think it's helpful. And Modern Fertility is one of those where they would test your AMH, they would test your hormones, they would test your thyroid in a way that has been clinically validated, published in the Green Journal, who, for the listeners here, is one of the premier journals. And they showed that, like, drawing blood and pricking your finger, testing these hormones with their assay is consistent. So I think that's the first step. You want to make sure it's clinically accurate. And then when you get your results, you not only have a very clear explanation of what they mean. They're not trying to be your doctor, but they're trying to educate you. This is high, this is low, this is what this might mean. Go see your doctor. This is not what we would expect at your age, and then have someone help you and then guide you from there. And I think, semen analysis companies do something similar. Yeah. I work for a menopause telehealth company that helps people get access to a hormone replacement therapy in a safe way, which is very difficult to do since the WHI study in America, because not a lot of people feel comfortable. So, but I also see the other side of the coin, where people are getting sold treatments for hundreds of dollars that have no medical validity, and it's a little bit predatory. So it depends where you get it is the right answer. I think.
No, it's a nuanced answer. And you're right. I think oftentimes, as a clinician in the office, I want to support my patients the best that I can. I want them to feel empowered. I want them to feel educated. And so when a patient comes to the office with data from another source, oftentimes the first reaction sometimes is like just being taken aback of, like, well, where did this come from? Is this company validated? How do I think through this company and make sure that they're giving, like, patients accurate information? And then, going from there. It sounds like you have some experience with Modern Fertility, obviously, as one of their medical advisors. Are there other companies kind of in the fertility space that you yourself have kind of either vetted just through your colleagues or doing your own research, or journals that you say, hey, if patients are trying to be proactive and access good fertility care that isn't necessarily, the standard care that they get from seeing, their OB in the office or being referred to a fertility specialist, that kind of in between of empowerment. Are there other things that patients should kind of be excited about or know about?
Sure. I mean, I'll say this with the full caveat that the ones that I'll mention, I am associated with. So I don't want anybody to feel like I'm selling them or you have to do them, or to think that this is the only group of companies that is vetted and everything else is NACO. We are very lucky to be in a field where people are trying to innovate. A lot of the founders in our field are patients. They struggled. They found how inconvenient, how expensive it was. And they said, I'm going to leave my corporate job, or I'm going to put my skills to try to make it better for other people going through. But there's certainly on the diagnostic side, where you're thinking about, like, testing, Modern Fertility is great for hormones. There's a company called Fellow, which, does at-home semen analysis companies. They've validated their tests. They've published their results. So you get a kit mailed to your house. You collect at home, you put it in the mail, you get results a couple of days later, and it helps you get a sense of your sperm. I think it works very well. It's convenient for males. No one has to take time off work, and it's at a very reasonable price, often sometimes cheaper than even doing it in a clinic. There's one called UVA, which, I advise as well. And they are essentially like a super accurate and precise ovulation predictor kit. They basically urinate in a cup and then dip their strip. But instead of being like, is the line dark enough? Is that positive or not? You take a picture with your cell phone, and they use machine learning and computer vision to see how dark that strip is. And they can give you not just a yes, no, but an actual number of how your progesterone and LH and estrogen are doing. So you're able, especially for those PCOS patients or people with irregular ovulation, it gives you a much easier way to track your cycles and understand whether you're ovulating or not, or where are you in your window, should you be having intercourse to try or not. So that's one of those that it has been really helpful for some of my patients that really didn't get positives or struggled tracking their cycles and their ovulation window. They have tried that tool and found much more success. So those are just a couple of the many out there that I work with most closely.
Yeah, no, it's helpful. And I appreciate you giving the caveat that you are affiliated with those companies, but also, again, for me as a practicing OBGYN and any OBGYNs who might be listening, patients oftentimes know about and have access to companies and tools and resources that we don't hear about, right? Because it's not part of our normal clinical practice. So having it, again, vetted by someone that I trust, it's always really helpful.
You can always text me and I'll tell you.
Great. Thank you. Anyway, so that's great. I'll pass it forward. Anyone who's listening right now can always send questions to me, and I'm going to text Dr. Hariton directly. So other things that I think about that really commonly come up is kind of understanding when a patient, maybe eventually there's a patient I've been working with, and I have a lot of patients who have what we call like unexplained infertility. I do all the hormonal tests that we talked about, right? Depending on their age, it's 12 months of trying to conceive under the age of 35, 6 months of trying to conceive over the age of 35. Once we hit that mark, then I'm ordering baseline hormonal tests. We're getting semen analysis for the partner, and then potentially getting a study to evaluate the tubes depending on their history. And everything comes back normal. And so those are the patients where I finally say, hey, okay, let's meet Dr. Hariton or one of his colleagues. I think it's time. When a patient, comes to see you, we already talked through the initial evaluation, but can you help those who are listening understand the difference between ovulation induction versus intrauterine insemination versus IVF, and, who's the client who needs each of those to help conceive?
Sure. So that patient you just mentioned has unexplained infertility, meaning doesn't mean there's no explanation, just means we're not smart enough to figure it out. Okay. I always tell my patients, like, unexplained infertility is the most frustrating kind of infertility. You're like, what's happening and why don't we know? But I always tell them, if this was like Harry Potter and you were trying to pick your infertility out of a hat, it's the one that you would want to pick, because it means that there's not a problem that we can't overcome. If we found out that you ran out of eggs, great, that's an explanation, but that means that it's going to be challenging to get you pregnant with your own eggs. Same thing with sperm. But if you don't have a problem that we can ascertain, then we just have to get those sperm and eggs closer together in some of the ways that we'll talk about. So it's the most frustrating, it's very common, but it's honestly the one that I hope my patients have, because we can typically overcome it with our treatments. Other reasons why people might be infertile: male factor, issue with the sperm, ovulatory disorders, so eggs are not coming out of the ovary, or there's few eggs left. A lot of times that's tied to age, but it can happen sooner for some patients. There could be issues with the tubes. There could be genetic issues that are leading to losses, and that it's something that we see often as well. So when I have that patient in my office, we've done the diagnostic, we've looked at all the parts. There's really three things that we do in our clinic. We can help people ovulate and either have them have sex or come and do inseminations. We can do IVF or in vitro fertilization, or we can do any of those things with donor gametes, meaning donor sperm, donor eggs, or a gestational carrier who can carry the pregnancy. So to start in the most basic way, for people who have been ovulating regularly but haven't gotten pregnant, and there's no great reason, so people with unexplained infertility, we can help them ovulate more than one egg at a time, knowing not all of them are normal and one at a time hasn't worked. And we can then take the sperm from the male partner and put it inside the uterus. So 95% of the way where they need to get to. So you get more eggs near more sperm through something called an intrauterine insemination, or IUI. It feels like a pap smear, speculum goes in, and a small catheter goes through the cervix and deposits all the sperm at the top at the exact time when we expect you'll ovulate, within 12 to 24 hours. So we know the sperm's closer, we know the eggs are coming because we've done ultrasounds, we've helped release those eggs, then we can increase that pregnancy rate a little bit. And that's something called supraovulation and IUI. For people that don't ovulate regularly, they have PCOS is a common reason why that happens. We can give people pills similar to the ones that we give for people with unexplained infertility, help them ovulate. And then if the sperm looks good, they can try and have sex at home. If there's a reason to do inseminations, we can. For women who are in same-sex couples or want to have children on their own with donor sperm, we can do a similar process. Often we don't need those medications because they're not technically infertile, but we can do the insemination part of things. So that's typically kind of the lowest tech treatment. Success rates vary anywhere from 5 to 15%, depending on the patient and the female age. So it's not the most successful treatment compared to IVF, but it certainly is a little bit less expensive. It's less invasive. It takes less time. And it's a great place to start for some couples. For people who have male factor infertility, that's a little bit more severe. If the tubes are blocked, if you have a genetic reason why you want to do IVF to test embryos, or for people who try those first few treatments and they're not successful, we often think about doing IVF. What we do in IVF is we take over your reproductive system for about a month. And then instead of growing one egg at a time, which is what most people grow with regular cycles, we give you the same hormones that the brain normally makes, and we make every little egg in your ovary that we can feel special and grow. And that could be 5, that could be 15 or 20. Those eggs are in the surface of the ovary. They're not eggs that were going to be around forever. They were going to die that month if they weren't chosen. So what we're doing is we're rescuing those eggs that weren't going to make it this month, along with the one that was, and we try to grow them over about a week and a half to 2 weeks. Once those follicles get big, we do something called an egg retrieval, where you come into our clinic. It takes somewhere between 5 and 15 minutes, and under some light anesthesia, so you won't remember the procedure, you won't feel any pain. We harvest those eggs and we give them to our lab. That recovery is pretty quick. You wake up, go home about 45 minutes later, and then most people go back to work the next day. And in the lab, we take those eggs, and if you are someone who's freezing eggs, same exact process up till then, we freeze those eggs and we keep them for you until you're ready to use them. But for people who are trying and having fertility, we will fertilize those eggs. We will grow them into embryos for about 5 to 7 days. And at that time, we can either transfer an embryo. We often do genetic testing on those embryos nowadays. So we make sure, especially for older women, that embryo is coming from an egg that has the right number of chromosomes, so that we have pretty high chance of giving that person a baby. And if there's an embryo that wasn't going to lead to a pregnancy, we find out before transferring it and, avoid a miscarriage or a negative pregnancy test. If people are carriers for cystic fibrosis or any sort of condition, we could do that testing at that time of the embryos to make sure that we are not transferring an embryo that will lead to a sick child. Obviously, we can't test for everything, but on I know we do a lot of genetic testing on couples to make sure there's no overlapping mutations that they might be at risk of passing on. People that have BRCA1 or 2 that they find out because an aunt or a cousin or a parent had breast cancer or ovarian cancer, we can screen for those mutations as well. So we do a lot of that to help couples have the best chance at a healthy baby. And then when we have the number of embryos that we want, they want 2 children where we feel like we have enough in the bank that we'll have some left over for the future, we can do something called an embryo transfer, where we thaw that embryo and we put it right inside the egg. And it feels kind of like an IUI, short procedure, drop the embryo at the top. And with genetic testing for most patients, about 60 to 65% of them will have a baby for that transfer. So we get really successful once we make those normal embryos. It can take 1 or multiple cycles to make enough embryos that we're ready to move into a transfer. And that's a little bit of that personalized decision. And
Mm,
then the third part of everything is sometimes patients come to us with not a lot of eggs left, or a little bit later in life, or they've tried different places and they haven't been successful, or the male partner doesn't have sperm and we've tried to aspirate it from the testicle or different ways, and we need to use a donor gamete. We can help people get pregnant with donor eggs and donor sperm. They're often coming from anonymous donors that are in a bank that have donated. I never call anything anonymous now. That's a misnomer, because in the age of genetic testing, it's hard to think that in the lifespan of your child, they will not find out that they have an association to someone else, just because genetic testing just gets more prevalence. But it's someone who you're not familiar with, and you can purchase those eggs. You can learn their history, what they look like, and find a donor that you're comfortable. And then if someone has a uterine issue, history of cervical cancer, or recurrent losses, or some reason why they're not healthy enough to carry a pregnancy but want to be parents, we often rely on the altruism of gestational carriers who might carry that embryo and that pregnancy for someone in the future. And for my LGBTQ plus couples, they often need a donor of some sort, and often and sometimes a carrier, so we can have those people help when needed as well.
Yeah, that's a perfect detailed summary of kind of the full spectrum of possible fertility care. And I also really appreciate you acknowledging, again, the individual, right? And one of the podcast episodes I've recorded already was talking with one of my dear friends who also is an OB/GYN in a same-sex couple relationship. And she shared her experience and how oftentimes when you're going to fertility practice, it's because there's an assumption of something is wrong, quote unquote, right? But oftentimes for same-sex couples, there's nothing wrong at all, right? That it's just that there's one piece that's missing, whether it's the egg or the sperm. And so I really appreciate that you guys are kind of thinking about approaching each person individually. So I'd like to take a moment to tell you this is my passion project based on years of experience as an OB/GYN doctor. I aim to empower moms and moms-to-be and those in the pregnancy and postpartum care space. If you appreciate what I do, please take a moment to like, subscribe, and share with your friends so it can reach more people like you. You can visit goldenhour.fm for more information, resources, and all other episodes. If you have any requests, suggestions, or questions for future episodes, please email me at hello@goldenhour.fm or leave us a comment at goldenhour.fm on Instagram. Something that you mentioned that was personal to me was, I don't know if you recall this, but over the summer, or maybe before the summer, I had chatted with you because my husband and I were thinking about freezing embryos, which we ended up doing. And I learned a lot. I know about the process, obviously, as an OB/GYN, but when you actually go through it, you learn a lot. And I truly empathize in a deeper way with my patients, because I injected myself for weeks, felt how it was to have like 2 grapefruit size like ovaries, and I agree that the egg retrieval was not too bad at all. But yeah, when you're in it, it's such a delicate and involved process. And part of the decision that my partner and I had made based on my own personal age is to do PGT, and it made total sense to us, or pre-implantation genetic testing. Can you kind of talk more about the pros and cons of PGT and who should really be considering it?
Yeah, no, that's a great question. And I'm glad you went through it. The nice thing for us is we were scrubs. So I always tell my patients, you're going to go through this, like, this is not like tight, skinny jean season. This is like dress and, yoga pants or scrubs or whatever's comfortable. It will all go down. So I'm glad you had a good experience.
Yes, I did.
In terms of PGT, so PGT stands for, like you said, pre-implantation genetic testing. So this is taking 5 cells out of what is usually a 1 to 200 cell embryo, and then amplifying them in a genetic testing lab to try to figure out, is this embryo genetically normal or abnormal? Does it carry a mutation? Does it not? Most times people do it to find out whether the embryos are normal. If you're 33 or under, probably about 70% of your embryos will be normal. By 37, 38, it's probably about half. By your early 40s, it's probably about 70-30 abnormal. By 43, 44, it's probably about like 85-ish abnormal. The the older you are, the more abnormal the embryos will be, the most benefit you can derive from this test, because what you're trying to find out is this an embryo that I want to transfer, or is this an embryo that I know will not be normal? There's no perfect testing, so obviously we don't want to over-test embryos. We don't think that they harm the embryos. It's hard to say it's better than not touching it, but in our lab, we do dozens, if not hundreds of biopsies every day. We biopsy probably like not 100 every day, except some days we do, but typically in the dozens of embryos every day. So the people that are doing this know how to do this. We do it with a laser. So if you go to someone that does one a week, not a good idea. You want to go to a high volume center that does a lot of genetic testing, because you can harm the embryo if embryologists are not experienced. But when we take those cells, we don't think we're harming that embryo. We're getting a result. And the result is our best guess at what the genetic content of the embryo is. Most of the times, about 95% of the time, we get a great answer. Either this is normal or this is abnormal. About 5% of the time, we get an intermediate answer, and that's called a mosaic embryo. So it could be like, not, in the middle, like it didn't give us a great read, because remember, we're getting an answer out of 5 cells. There might be some cells that look normal or look abnormal, so we can't tell for sure. Some of the times we are able to transfer that embryo, some of them are not. So what I tell patients is, the older you are, the more benefit you have. I'd say above age 37, 38, usually recommended to my patients. Below that age, I leave it up to them, and I explain the pros and cons, and I say, most of your embryos are going to be normal. We're going to have a higher pregnancy rate per transfer if we know which ones are normal first. But if you are transferring all of your embryos, you can't beat that, right? Because if you're giving every embryo a chance, you might put yourself through a miscarriage that you might not otherwise have. You might put yourself through a transfer that we could have found out wasn't going to be successful before you actually do it, but you're not going to do better than transferring every single embryo. And for every patient, it's a little bit different. If you're going to get a lot of embryos and you're older, it is especially useful for someone like you, because if you get 10 embryos and 7 out of the 10 on average are abnormal, that's a lot of failed transfers to go through. And we can't really tell under the microscope. So I would say almost all my older patients do it in the Bay Area. And a lot of my younger patients want to do it, even though the benefit is a little bit less for them, because they want to know, especially when they're saving embryos for the future or not. So to me, it's more about educating my patients and giving them all the information they need. Some of them choose it, some of them don't. And it's okay either way, as long as they're going into it having the right information. And the last thing I'll say is, people ask me, well, are we throwing away embryos that were normal because the test was wrong? And no test is 100%, but my colleagues at RMA in New York or New Jersey did a study. They call it a non-selection study, where people went through IVF cycle, they tested the embryos and they transferred them without knowing the results. So the ones that came back normal had an 80% pregnancy rate and a 64.7% ongoing pregnancy rate, meaning live birth. And for the ones that were abnormal, about 40% of them had a positive pregnancy test. About 20% of them had something on ultrasound, but none of them had a baby. So that tells me that, nothing's 100%. So I'm sure, 0, I never believe a 0. I believe a 0.1, a 0.5. But that tells you, like, the embryos, at least with the platform that they use, that they're excluding, they were not going to lead to a baby. So that gives me comfort that we're not kind of like excluding a lot of babies and putting them in the freezer, especially if you go to a clinic that actually differentiates not only just between euploid and aneuploid, meaning normal and abnormal, but also gives you that category of mosaic so that you can get that extra information.
Yeah. No, I think that's such a thoughtful approach, and a big theme of what we're talking about not only is individualized care, but empowering patients. And I felt like I walked away from my own experience. I'm 37 years young, turning 38 in a month. And so I walked away feeling empowered, knowing that, if and when my husband and I do decide to use those embryos, we definitely knew that we didn't want to necessarily be rolling the dice, if you will, and gambling. And so knowing that our odds were much higher to lead to, not only a pregnancy, but hopefully even a live birth, I think was really important for us.
And I think other thing that's super helpful is, let's say you, I don't know when you want to start your family, but let's say you wanted to wait 5 years and you wanted to start it when you're 42. It's not that those embryos were going to change in those 5 years, but if you got, the unlucky side of the coin a couple of times and the embryos were genetically abnormal, you would have found out 3 weeks later, and then you can go through another cycle and do this again while you're still 37, right? Whereas if you decided that you weren't going to test them, you might have had the same pregnancy rate that you would in 5 years. But if you thaw them and you go through it and you're not pregnant, then you couldn't use that information at age 37 when you could still use your 37-year-old ovaries to make more. You were now left at 42 using those 42-year-old ovaries to make up that. And I think it's really that information, and when you get it, that is really actionable. That's when I talk about my couples that will freeze embryos together and not eggs. Is I can tell you on average, freezing 15 eggs at age 33, you can expect an 80% chance of having one baby and a 40-something% chance of two. But it's 0 or 100 at the end of the day. And I don't know how many of those eggs will thaw and fertilize and grow and be normal. So when you freeze eggs, you're so much further away from a normal embryo and a baby that the possibilities are much wider. If you go through that funnel and they already fertilize and grow, and especially with genetic testing, you are much closer to that baby. And if you don't get any normal embryos, you find out right away rather than find out years down the road when you're ready to have a baby and have a lower chance of being successful trying.
Yeah. Well said, as always. Another guest I had the honor of interviewing was a good friend who ultimately is relying on surrogacy for her family planning. Can you kind of elaborate a little bit more on who is the person who may or may not need to use gestational carrier or surrogacy for their family?
Sure. So typically, there's some people that have medical reasons why they can carry, like they have pulmonary arterial hypertension or they have some medical problem where it's not safe for them to carry. There's some people whose uterus is not able to carry. They've had recurrent miscarriages despite treatment. They had a hysterectomy for some sort of cancer. They were born without a uterus. And then, people that might tried in their own uterus, did IVF, they're not getting pregnant. They have scar tissue in the uterus. We can't get their lining to grow. They have had a placenta creta or some sort of placenta that attached to the uterus. So the risk of them having a very significant issue, people with a history of severe preeclampsia, HELP syndrome, all the things that Ono gets scared about and she doesn't want to think about before she goes on call tonight. All of those things where the mom's life would be at risk or the baby's life would be at risk are reasons to consider having someone else carry. It's not a decision that anybody takes lightly. Certainly, it's very expensive. And to put some numbers, it can cost $150,000, $200,000. It's a very expensive process. Part of that is you have to compensate the surrogate for her time. You have to compensate the clinic for the process of making embryos. And, it takes anywhere from 6 months to 18 months to find a gestational surrogate. And that's something that it's certainly an incredible way to help families have children. So same-sex male couples could not do this without a gestational surrogate. A lot of women with medical issues or who tried and failed cannot do this. So it's one of those things that I'm glad it's in our arsenal of tools to help people. But it's certainly both very expensive, out of reach for some folks, as well as something that takes a lot of time and coordination to make happen.
Yeah. The guest that I had on earlier, Emma, said it so thoughtfully. She said that, in her journey, she just recognized that the altruism of everyone involved, whether it was the gestational carrier, the medical team, the lawyers, right? It's a lot more people involved in creating a beautiful life. And so it's a big process, but a really deeply rewarding one for those who need it. So yeah, glad that that's an option.
Yeah, no, absolutely. I look at this process and I'm like, it's great that it's there, but it's somewhat broken. Like the fact that it takes you 12 to 18 months to find someone to help, the fact that it costs so much. And I like to take care of patients of all walks of life, some of which struggle to pay for an insemination cycle, but they might need something like this. I'm looking forward to seeing technology come and disrupt this process. And, I have a good friend and colleague who works out of New York. His name is Brian Levine. In New York, they basically looked at surrogacy and they made it legal over the last couple of years. And he said, wow, this is a broken system. What can I do to make this better? So he started a company where they're now helping surrogates come in, and the surrogate gets to pick the couple. So the matching time gets a lot shorter, and it expedites a lot of the process. The agency fees are a big part of the expense, and he's trying to lower that to make it more accessible. So it's people like him and that are looking at these industries and saying, like, there's a lot of demand for this, but it's not working out well. How can we incorporate technology to get more people to come in? And, most women want to help. Not everybody wants to carry a baby from someone else, but a lot of people would be happy to. They don't feel terrible in pregnancy. Every surrogate has to have had a child before, so they know what it's like. We know that their outcomes were good before we sign them up to carry for someone else. We make sure they understand pros, cons, risks, etc. And for a lot of people, the money they make in surrogacy is very helpful to support their own family, their children, their own goals. So it's a nice way to get everybody aligned. And I love seeing technology come in and make a difference in a process that otherwise is tough. So I'm hopeful that the cost of having a baby through surrogacy will go down over time.
Yeah. No, I'm inspired to hear that. And that's a great segue, because I also want to touch on is the way that your brain works as someone who is MBA trained and clearly has a lot of influence with several medical health startups. What are the other things that you are looking forward to, innovations in the fertility field that you're hoping kind of disrupts the way things are, or things that are kind of maybe working in the background?
Yeah. So, I always tell people that, we've been doing IVF for 45 years, and we went from like triplets and quadruplets and 5% pregnancy rates and not being able to help male infertility or freeze eggs or embryos that, very few survive, to 60 to 65% pregnancy rate, survival rates of 95, 98%. Almost everybody does a single embryo transfer, which has a lower risk of having twins than having sex at home and trying naturally. So we've gotten much, much better on the scientific side, but not so much on the serving the patient side. You still call a clinic, make an appointment, show up, talk to me, do a bunch of tests, come back and talk to me again. And that process is still complicated, expensive, life disruptive. The things that I'm excited about are, I love the science, but there's a lot of people doing really good science. It's taking a step back and saying, like, how do we get a woman or a couple to go through this process and not feel like it takes over their life? How do we get them, they want to come to me, they come to me with the right education at the right time, so that they don't need to see me to get some of the things that we're talking about today. They can get them through technology, through like validated, vetted sources, not TikTok or someone who's dancing. There's great stuff on TikTok and Instagram, but you gotta make sure it's coming from the right source, and that source does not have a conflict of what they're trying to recommend or sell to you. And what I also say is, I want to make sure that people come to me prepared for that appointment. So that's why I appreciate you so much, because you always tell that patient, this is what's going to happen and this is what he's going to need. So you're going to see him in 2 weeks or a month. Let me order all the tests, bring it to him. Because that way I'm sitting across from them and I'm saying, this is where your labs showed, this is what your sperm showed, these are the options that we have. Let's make a plan. And the time to treatment gets much shorter. If I have to tell them, like, well, if you have a lot of eggs, we'll do this. If you have not that many, we'll do that. If the sperm looks good, we'll do this. If it doesn't look good, we'll do that. That's a little overwhelming and not really actionable. So I like, especially when I get patients that have done the workup, I want to get them in to treatment quicker, which is why they want to. I think there's a lot of technology in terms of diagnostics to make us understand issues better. There's my thesis in fellowship was using artificial intelligence to help make better decisions during stimulation, to try to help to optimize the outcome. And I work with some companies trying to bring products to market that help us really do that. So helping make better decisions through looking at embryos. Like my embryologist can look at and they say, well, this one looks like an AA, this one's an AB, but that's someone who looks at hundreds of them or thousands over their life and is making their best educated guess. Mm-hmm. Or we can have a computer look at 2 million pixels that are all type 2 outcomes. They're not biased and help us pick better embryos. So there are studies going there using AI to pick embryos to understand, are they better? There's also a big element of QI, QA. Doesn't matter if the embryo is rotated, doesn't matter if the embryologist is tired, the machine's going to be consistent. And we do a lot of work with that. And then, those are just some of the technologies. We're always thinking about, for the patient that I mentioned, hey, I froze 15 eggs. Are those good eggs or bad eggs? We don't know. There's no rating scale, but there's companies that are looking at those eggs and trying to help predict, are they more likely to make babies, less likely to make babies, and help patients counsel? And, and the last one I'll mention is something that we built in-house in our company that I was lucky to be leading and involved with was, when you come to me and you say, Doc, I can't get pregnant. I don't know if I should do IUI or IVF. What are my chances? What do you think? So we built a model based on all of our data. We're part of the largest fertility network in the country. And we wanted to build this predictor tool to be able to show patients, like, what's the likelihood that you're pregnant in 1, 2, or 3 IUI cycles, or 1, 2, or 3 IVF cycles? How many eggs we expect to get? How many embryos might that do? To give you a sense of what to expect. It's not going to change the outcome necessarily, but it helps you and your partner, if you have one, make a much more educated decision about what's the right approach and which way do you want to go. It also helps people who might not have the health background understand that when I say it might take more than one cycle, a lot of people just hear, I know you have to say that, but I'm probably going to just take one. Like, it's so expensive, it has to work. And you go through that cycle and then they're not pregnant or they didn't make a normal embryo. And they're like, what happened? And I say, I was really hoping you would be in that 60% of people that got pregnant in the first cycle. But unfortunately, you weren't. You were on the 40%. This is what we learned. These are some things that we might want to tweak. But it does take more than one cycle for the average patient. If you kind of meld all ages, every patient that comes to our clinic, it may take 2 to 2.5 cycles to reach a baby. And if you're older, your reserves lower, or you want a bigger family, that might be even more. So that tool really helps me give patients real data and help them understand, we hope to get you pregnant in 1. That's always going to be my goal. But on average, it takes more. And here are the statistics for someone that's your age, with your ovarian reserve, with your partner's semen analysis. And that, I think it's really helpful to use the power of AI and information to help patients get the right data.
Yeah. I mean, there's a theme. Every podcast episode I have is there's always a theme, and I think our theme continues to be like individualized care and empowering that patient. I think back to one of my earlier guests who was a friend who went through her own fertility journey, and it feels like it's more and more common these days, and also just because we all just also get older. And part of what she shared was this feeling of like, feeling, although they ultimately ended up with a beautiful baby boy and the outcome, they got the outcome they wanted, feeling like it wasn't tailored to her, feeling like they just were kind of using the standard regimen of medications, but she didn't feel like she got the sense of information that was very specific to her and her outcome. So it's great to hear that resource is out there. Eduardo, this has been amazing. And I know that you are actually squeezing me in the middle of a work day. But I think I have one final question for you. What would you say are some of the most common misconceptions that people have about kind of fertility, that you spend time kind of helping debunk or explain away to patients?
So many. Let's see. One is birth control lowers your fertility, affects your fertility. A lot of people go on the pill when they're teenagers and then they come off and they're like, I don't have periods, the pill messed me up, or this and that. The pill masks a lot of issues because you take it and you're having what you think are regular cycles or regular withdrawal bleeds from the medication. So the pill is very good at masking a lot of things, but they don't necessarily cause it. And we have great data to show that people, that when they come off the pill, they might have an issue, they might not, but it's not because of the pill. Another one is you need to take out your IUD to do an IVF, like an egg freezing cycle. That's not true. You can go through an egg freezing cycle or an IVF cycle. You need to take out the IUD to get pregnant, but if you're banking embryos for the future, you don't necessarily have to. Another one is, I don't want to go to IVF because I don't want to lose more eggs than I have to. And IVF, like I mentioned before, doesn't lower your fertility, doesn't make you any less likely to get pregnant. It just rescues the eggs that were going to die that month and saves them for you for the future. So that's not something that we worry about as much. And then the last one is, coming to my clinic doesn't mean that you have to do treatment. Oftentimes people come and I talk to them and I say, well, you don't really need me. Like, you guys have gotten pregnant, someone has had a miscarriage or not. And I help, we go through the workup, we test the things that we need to test. It all comes back normal. And I say, if that was really tough, yes, you can do IVF and do genetic testing and find a healthy embryo. And that might lower your miscarriage rate a little bit, because most likely it's because that embryo wasn't the right one for you that month. But you don't necessarily have to. Sperm looks good, tubes are open, you're getting pregnant. You can go home and try, and I'll be here to support you if things haven't worked out. So making an appointment with a fertility specialist does not require you to go to treatment. And, to your last point, I think it's really important to have a medical provider that you trust, whether that's your OBGYN or your fertility doctor. If you are in a medical relationship with someone and you do not trust that person, whoever that is, if it's me, if it's you, you have to find someone that you trust, because there's a big information asymmetry. There's a lot of stress going through this process, and a lot of that you're delegating to your doctor. If you can't trust your doctor, if you feel like everything they're doing, you have to read on your own and second guess, you're not going to have a good experience. So if that person hasn't spent the time to build that trust, ask for that and be proactive. And if they are not willing to give you the time, then that's probably not the right person for you. And I know how difficult it is to go through a fertility journey. Like I said at the beginning, no one likes to be in my office for this. You want to make sure that you're with someone that you feel has your best interests in mind and is making the right decisions, because it's going to make the emotional part of this a lot easier. And I always tell people I'm 20% fertility doctor, 80% psychologist for my patients. And I love that part because I really get to know them. But helping people manage how they feel emotionally going through this process is really the hardest, but also the most rewarding part of the job. And you need someone that you feel has your best interest in mind and is connected with.
So well said. So well said, Eduardo. With our final moments, are there any kind of final words that you want to share with the audience that's listening? Any final pieces of advice?
No, I just want to thank you for giving me the opportunity to come on. It was fun to chat as always and nerd out a little bit on fertility and technology, and I'm just grateful for the opportunity to chat. And, anybody, like if you're listening to this and you're like, oh, that resonated with me, that makes sense. Like, Anna knows how to find me. You can find me online. I'm hoping no one here needs me unless you're thinking about freezing eggs, and if you're struggling to get pregnant, just know that you're not alone. This is the thing that no one likes to talk about. Your colleagues at work are struggling too, and your friends are struggling too, and it feels really lonely. So find that couple people that you really trust and open up, because it's a very tough thing to go through solo, and it's much more common than anybody thinks it is. People just don't like to talk about it.
Yeah. Thank you, Eduardo. No, it's true. The premise of this podcast really is to create community, create a space where people don't feel alone in whatever they're struggling with, whether it's breastfeeding postpartum or trying to get pregnant, right? And everything in between. So this conversation has made me feel good. It's made me feel empowered as someone who has the honor of caring for so many wonderful women. And I hope that whoever has the honor of listening to not only is left with some vetted, real information, not just like TikTok dancing, but also just, leaving feeling empowered and not alone. So thank you again, Eduardo. Really appreciate you today.
Thank you for having me.
Thank you very much for listening to The Golden Hour, the podcast community where moms and moms-to-be can hear stories from other mothers and learn from top experts in pregnancy and postpartum care. If you enjoyed this episode, please take a moment to like, subscribe, and share with your friends so we can reach more people like you. You can visit goldenhour.fm for more information, resources, and all other episodes. If you have any requests, questions, or suggestions for future episodes, please email me at hello@goldenhour.fm or leave us a comment at goldenhour.fm on Instagram. Looking forward to seeing you in the next episode. Until then, stay golden.